In the last 30 years, the world of science and the HIV and AIDS community have worked together to control the HIV epidemic. How? With incredible resilience, a united spirit, and an unwavering focus. These qualities have always defined the HIV and AIDS community. Despite the challenges faced, whatever tried to stand in the way, the community didn't give in, and we kept going. And right now, despite a new wave of challenges, still, we have to keep going. Until fear becomes hope. Until there are no new HIV infections. Until ignorance becomes acceptance. So people living with HIV are understood and accepted. Until born with becomes born without, when no more children are born with HIV. We won't stop until ambition becomes success. And research offers more ways to treat and hopefully one day cure HIV. We won't stop. ViiV Healthcare, here until HIV and AIDS are not.
Welcome to this ViiV-sponsored virtual scientific symposium at Interest 2020. The symposium is entitled The Art of Pediatric HIV, an African Perspective. My name is Michelle Kisare, and I'm ViiV Healthcare's Regional Medical Scientist for Middle East and Africa. Today, I will be joined by two eminent speakers. Firstly, we will have Professor Mark Cotton, who will be presenting on the evolution of pediatric HIV management in Africa. Second, we will have Dr. Serufusa Sekidde presenting on the role of dolutegravir in pediatric HIV management. Please note that this session is intended for healthcare professionals only. The first part of the symposium is pre-recorded, but please join us for a live Q&A session thereafter. We request that you submit your questions throughout the session using the Q&A tab provided so that we can address them later during the live Q&A. Thank you for joining us. I hope that you enjoy the session.
Good afternoon, everyone. It's my privilege to give an overview of the evolution of pediatric HIV management in Africa. This is quite a challenge to do in 20 minutes, and I'm going to be relying a lot on my own experience through this pandemic when it started and where we are today. Firstly, in the pre-ARV era, we had despair, and we were faced with many children with untreatable conditions. That was extremely emotionally challenging for least of all for the children and their families, and also for us to manage these children. And you can see a picture of a little boy in this slide who was really hard to treat. Looking at the data that was coming out in the pre-ARV era, this is data from this Vitambo study from Zimbabwe, and it looked at infant mortality at 2 years of age, and comparing children who were not exposed to HIV, those that were exposed but not infected, those with perinatal or postnatal infection, that's through breastfeeding, those intrapartum and in utero. And you can see that for those in utero and intrapartum, the mortality by 2 years of age was almost 70%. And that is what we were dealing with. I want to present a patient who we saw in 1996. This little boy was aged 9 months of age, presented with upper airways obstruction and right heart failure that was probably due to adenoidal and tonsillar hypertrophy. In those days, there was no PCR, so we had to rely on antibodies. And out of desperation, we treated this child with a single drug, AZT, and he actually resolved these symptoms and could go home quite remarkably just before tracheostomy was going to be done. And this is really the first documented clinical benefit of an antiretroviral in a child in Africa. So there were things we could do, but not much. And at the time, there was a terrible political conflict, and the South African government of the day would not support preventing transmission of HIV in pregnancy until lawsuits came along, and eventually it's prevention of vertical transmission actually happened. And looking how we started and looking at an ARV program today, you can see that the tools for a program were actually established during the vertical transmission prevention programs that started from scratch, from absolutely nothing. And this included rapid antibody tests for diagnosing the mother, starting with counseling that the pregnant women could be counseled for the first intervention, which was single dose nevirapine, was very simple. And even though it helped a bit, it wasn't very effective, but it was a reasonable way to start with incremental improvement until we introduced combination antiretroviral therapy from diagnosis and continuing for life, as is being done now. And this is really what facilitated the rollout. You can see this is a study from Bev Draper and Farid Abdullah documenting this program in the Western Cape starting in 1999 with AZT, and then the gradual and grudging rollout through the entire province over a 3-year period, and a slight strengthening of the antiretrovirals on offer as well, and then until what we have today. So in 2004, early infant diagnosis was really in its infancy. One relied on symptomatic disease and antibody tests, or if the mother's antibody persisted for up to 18 months at that time. And in the South African guidelines at that time, PCR was mentioned as a possibility, but not as something that could be done. And it's quite dramatic and impressive as to how rapidly this was actually rolled out to the whole country. Looking at our own clinic and looking at ARV access that we had, I've already shared the case report, and we have a little case series as well. And gradually we were able to introduce antiretroviral therapy to small numbers of children in a variety of ways, including medical grants, some early ARV studies that we were able to do, some donations, a marvelous NGO called HOPE, who started sponsoring children at our hospital. And then in 2004, we rapidly put lots of children on antiretrovirals when it was available. And this was really mirrored in other parts of South Africa and also in the continent. So in those days, we started late, so the children were sick, and we were very happy to get access to the antiretrovirals. But the children needed lots of therapy. And this is a little boy who survived with CMV eye disease, disseminated BCG, and also had HIV. And you can see the medicines that he had to take every day with a wonderful mother who was able to help him. So therapy was a bit difficult. Lots of liquid formulations, not great. Some, such as Zerit, required refrigeration. You needed syringes, and the caregivers needed good eyesight. So this wasn't so easy to do. And then, of course, we have the bad tasting medicines, such as ritonavir, that's really, really not well tasting. And in some parts of the country, this started as one of the ARVs of choice, and it still bedevils us until recently with having to use this. So now I want to go to early antiretroviral therapy and mention the SURE study, of which myself and Avi Violari were co-PIs, and we had lots of support and input from an amazing group of people who helped us put this trial together. And this is really point number 4 then, which is ART and infant diagnosis, early ART and early infant diagnosis, because until this time, it had not really happened. And you can see, looking at the baseline data for this study, we were starting ARVs in 2/3 of the patients at 7 weeks of age. And the other group were the deferred group, who we compared to the early group. So what we showed quite quickly was early ART really made a difference. And you can see that the difference was measured in death. So 4% in the early versus 16% in the deferred. And this data was so clear-cut that it led to lots of guideline changes all over the world towards early antiretroviral therapy. And this is one of the underpinnings then of the ARV program for children. And it's all based on data. And at the same time as early therapy came in, it had to be supported by early infant diagnosis that was reliable. The next phase is simplification, and we've already shown you how difficult the dosing was, and the weight band dosing came in, and also a reasonably simple, very simple ways of giving the medicines quite simply, according to a weight band, so you didn't have to work out surface area. And you can see also that with emerging PK data from 10 years of age, many drugs could actually be given once a day already. So this was a really great thing. And the next issue was working on the simplification. And as you can see through research done by Di Gibb and colleagues, simplifying lopinavir, ritonavir from horrible tasting liquid to mini tablets, combining NRTIs into tablets, dispersible and scorable tablets, really made a big difference. You can see bottom left, again through Di Gibb, the early fixed dose combinations that were developed, D4T, 3TC, and nevirapine, again, an adult, a child, and a baby dose to make it really easy to give. And even more recently, the 4-in-1, which is taste masked granules of lopinavir, ritonavir, and 2 NRTIs in granules that can be poured onto food, is in development and doing quite well. So the next important step comes with the Mississippi baby. And this was an infant baby, a newborn baby with a high risk of infection. The mom only presented in labor for the first time for antenatal care were shown to have HIV, and the doctors decided the risks of HIV for the baby were really high, so they started treating immediately, probably on the second day of life. And this child, the mom got a bit tired of giving all the medicine, so withdrew from care. And when the child came back, appeared to be in HIV remission and was in HIV remission with negative viral loads for almost 2 years. So this single case and some other work showing loss of follow-up on children at 6 weeks of age changed the dynamic to birth diagnosis and starting ARVs as soon as possible after birth if positive. And that again has been another shift in our treatment, also with the hope that if we were to treat early, possibly we could have more Mississippi babies around and might even have more children who could possibly go into remission. So that was part of the thinking that went into day one diagnosis and day one treatment, where very early treatment in the first days of life, where it was possible. Another emerging area has been the focus on all newborn babies, and even including the premature and low birth weight babies. And you can see we call this the last and the first frontier. Last to be studied, but with preterm birth, these are the first babies to be challenged with an HIV issue. And the next area that I want to address is dealing with TB. You all know that in Africa, especially Southern Africa, TB is really common. And the first point is that antiretrovirals reduce the incidence and prevalence of TB. So the first study on the left is one by Liz Walters, who followed a cohort of children retrospectively and could show a ton of TB in the pre-ART era, and on ART, the prevalence just became much, much less. And if you look at the figure on the right, you can see what happened in the Sher study, where there was a more than twofold difference in TB in children who started ART later. And that later was at 6 months rather than at 7 weeks. So using ARVs is really important to reduce the risk of getting tuberculosis. The next issue with TB is the treatment, and for drug-sensitive TB, you have rifampicin, and rifampicin reduces exposure of many ARVs, particularly nevirapine, which is the NNRTI that we've been using early on in life, and also lopinavir, which is normally combined with ritonavir, but the little bit of ritonavir is not enough. But by super boosting so that you have the same milligram for milligram levels of lopinavir and ritonavir works, although it doesn't taste that great, but it does work, and the lopinavir exposure is okay and you don't get resistance. And then more emerging data very recently is with dolutegravir, which is a well-tolerated drug, that by increasing the frequency from daily to twice daily, one can overcome the rifampicin effect. So, the options for children with TB and HIV are getting much better. The next phase to consider are the reality checks. And we've made tremendous progress. We've seen tremendous survival of children, but the reality checks come with the implementation. And again, this is a look at the areas, the clinics around where the SURE trial was done. And what it shows is that after the trial, even though there was some early treatment under 12 weeks of age, the children were pretty sick. And a small percentage were in optimal shape, whereas most actually already had severe disease, just illustrating that HIV in infants can really progress quite rapidly. Another reality check is adolescents, young adolescent girls are at risk of acquiring HIV, and this is a huge issue. And I've just added over there the amazing data on long-acting cabotegravir in combination with rilpivirine. So that will be a very exciting development. Another reality check is the rising prevalence of resistance and children on second-line treatment. And what you can see is that over time, the number of children with resistance and needing second-line therapy is increasing. In Africa, it's been somewhat delayed by lack of viral load testing and lack of resistance testing, but this is being addressed and this is getting a lot better. So we should probably be treating more children with second-line and even third-line antiretrovirals than we are, but the data is the formulations, the choices, etc., are improving, and we are looking for better results in this area. Having said that, there's also a good awareness that where there isn't good adherence, there are things going on in the home that need to be addressed through good counseling. So when one looks back, we've really made considerable progress. And when we think about this, probably the most important part of treating children and bringing them through childhood, adolescence, and adulthood is how are their brains? Are they protected? Are they doing well? And this is some data from the SURE trial by Barbara Lawton, showing that after 5 years of antiretroviral therapy, the children were actually performing as well as age-matched controls from the same community. That all the lines are going slightly down, we think is related to the norms being based on UK children rather than on children from South Africa, where a lot of standardization would probably be necessary. But we see this as a very good outcome. So a lot of the children are surviving and thriving, and you can see children climbing trees over here at a camp and really behaving really normal kids. And I think this is the best part of the ARV program to date. There are tons of acknowledgement. Lots of people have helped with this kind of work, and I've listed some of the people over here. You can see bottom right are the SURE team. It's with Avi Violari, my co-PI, Ab Babica, and Di Gibb, both of whom gave the expertise needed to make this a good trial. And Ed Handelsman from the NIH, who supported us all the way. And tragically, he passed away when we at the meeting where we were presenting our final results, which was really something. What an incredible person. And then our team, and of course the parents, the caregivers, and the families. And thank you very much. It's been a great privilege to share these thoughts with you.
Hi, I'm Serufusa, Sekidde, and I'm the Global Medical Lead for Pediatrics within ViiV Healthcare. I'm excited to talk to you today about the role of dolutegravir in the pediatric management of HIV. Full disclosure, I am a full-time employee of ViiV Healthcare. ViiV is committed to leaving no child living with or at risk of HIV behind. This is part of our core mission, and we have a unique and complementary pediatric portfolio that has innovative products as well as mature products that cater for children who are living with HIV or at risk of HIV. As we develop our future pipeline, we are really keen to do more and really keen to work with partners ranging from governments, non-governmental organizations, healthcare professionals, and everyone to make sure that we are doing our best for children who are living with or at risk of HIV. So here you will see our pediatric portfolio. You will see that we have products like AZT, which are our legacy products that have been used for quite a while. We also have newer products and formulations like for dolutegravir. Now, for example, we recently got approval for a dolutegravir dispersible tablet in the US for children who are 3 kilograms and above 4 weeks of age. We also got an extension of the film-coated tablet indication to now include children who are 20 kilograms and above. We've also recently got, for the one I've just talked about, a positive CHMP opinion in the EU, and we are soon expecting an approval. Now, just to be clear, the indications and the formulations that I've just mentioned have not been approved in any other countries, and therefore you should adhere to local regulations and guidelines when using dolutegravir. Here you will see the recent updates of the major guidelines. Now, the 3 of them, the World Health Organization guidelines, the DHHS guidelines, and the PENTA guidelines have recently been updated. As you can see here, the changes have happened across all age groups. The key update is that first-line therapy in treatment-naive children increasingly favors integrase inhibitors or boosted protease inhibitors with 2 NRTIs as the preferred regimen for children who are 2 weeks of age and above. The focus is increasingly on integrases, and this is because integrases have superior efficacy when compared to protease inhibitor containing regimens or NNRTI containing regimens, and this is due to their superior virologic efficacy, lack of drug interactions, and favorable toxicity profile. Now, these recommendations are largely based on extrapolations from adult comparative trials, and clinical investigation of these integrase inhibitor-based regimens in children has been limited to non-comparative studies that have evaluated the safety, tolerability, and PKs of these drugs. In this slide here, we'll now focus a little bit more on the World Health Organization guidelines, which are increasingly used by most low middle-income countries and adopted for national guidelines. Now, 3 main things to say about the World Health Organization updates in 2019. One is that they now include dolutegravir-based regimens as the preferred first-line regimen for infants and children aged 4 weeks to 10 years of age. 2, these recommendations now facilitate and increasingly focus on facilitating effective transition to more clinically appropriate regimens. Now, when we say transition, we're talking about the substitution with a different ARV or replacing a specific dosage form with an improved formulation of the same ARV drug. Now, there is an increasing focus as well on increasing harmonization with one World Health Organization weight bands, and this will simplify prescribing for healthcare workers. And two, they also talk about harmonization to ensure that younger children regimens facilitate the adoption of preferred regimens for adolescents and adults. Now, for example, the use of dolutegravir together with abacavir and lamivudine will facilitate a transition to dolutegravir in combination with TDF or lamivudine in adolescents. Here you will see that it's clear that dolutegravir is a core agent for today. It has a number of characteristics that make it a suitable candidate for the core agent of choice when building a regimen for treating HIV in children. Now, many of these characteristics actually align well with the challenges that we face today or that are associated with a regimen. Now, for example, it's been seen to have superior efficacy in naive patients in 5 comparative studies, and these studies were against core agents in 3 different classes. It also has a high barrier to resistance, and this has been seen in both in vitro and in vivo studies, and there were no treatment emergent mutations that led to drug resistance detected in any of these phase 3 trials of treatment naive subjects. You also see that it has a really good tolerability profile. For example, in the single study treatment with dolutegravir plus lamivudine and abacavir, there were fewer discontinuations versus Atripla, which contains efavirenz as its core agent at 144 weeks. It's also booster-free, which means it's likely to have few clinically significant drug interactions. And lastly, it has very convenient dosing with the ability to use it for once a day in most situations. We're also really excited to share a little bit more around what we are doing to drive access for pediatric dolutegravir in low middle income countries. Lately, and over the last few years, we've been investing in research and development to ensure that we can have the appropriate extension of the indications and formulations that we've been working on. We've also been really keen to develop and explore with others how we can develop innovative regulatory review pathways that allow us to have quicker access to our formulations in mostly African countries. We've also really partnered with organizations like CHI and UNITAID and worked with those who hold our voluntary licenses to make sure that they expedite generic development of a scored dolutegravir tablet within those countries and geographies that need them. And we're really excited that we're bridging the gap between the adoption and the availability of generic dolutegravir from what would have previously been a number of years to being a few months after the introduction of our own dolutegravir. We've worked really hard to accelerate manufacturing, and also we have worked to look at ways of making sure that we have favorable pricing that allows proper and efficient access to children who are living with HIV to this important medication. Lastly, I'll say that GSK and ViiV are committed to effective collection and management of human safety information relating to our products. If you see any adverse events with any of our products, please contact us on this email address. And thank you so much, and please enjoy the rest of the symposium. Thank you.